Hi, today we're going to be doing the um, head, ears, eyes, nose, and throat exam. And my name is Diana, and I'm going to be your nurse practitioner. And as I would begin this exam, throughout the exam, I would be observing her mental health and her skin condition. And looking at her mental health, I'd be looking at her appearance of her clothing. What has she worn today? Is it clean? Is it dirty? Is it kept? Is it unkept? Does she show any signs of restlessness or anxiety by moving and kicking a knee? Is there any immobile parts or anything that's moving that she's not moving of her own? I would also be assessing her speech throughout, and that is for articulation, the clarity, the speed, and the articulation. I would be looking at her mood and any signs that she seems pleasant and at ease with me, and ask her if she's got any trouble with depression or sleep patterns at home, any change in any of that. I'd also be checking her orientation and cognition, that she's alert and oriented times three, by asking her name, her birthday. I would ask her the date. And I would also go over some short-term and long-term. Long-term memory, I might test by asking her a past event from history. And in her short-term memory, I would state 5 words and have her repeat those 5 words back to me. If there was any further concern, I could also have her count backwards in increments of 7, and we could always do a mini mental exam. I would be checking to make sure that her affect and labile are of normal affect and relaxed, or what is that condition. I'm going to come around, and I'm always first inspecting, and so I'm looking at the contour of her head and her facial symmetry, and I'm going to begin to get ready with my hands have been washed and placing on gloves. I will be doing the inspection and palpation of her head, and I'm going to be feeling for any skull for lumps and indentations that might be indicative of traumas or past surgeries, her hair texture. I'm going to be looking for the condition of the scalp. Is it scaly? Is there any signs of infestations? Again, as I'm looking at her, I'm observing her facial expressions and contours. The skin, is it color, its pigmentation, the hair distributions, and any lesions or rashes, and I don't note any today. And her skin is also warm and dry. The position and alignment of her eyes is in sync, and the eyebrows are thick and bushy and in alignment. Her eyelids, I'm going to be checking the width of the palpable fissures, the edema and color and lesions, the condition and directions of her eyelashes, the adequacy of closed eyelids. This I will also be taking a look up. I'm going to pull up on your eyes and have you move them around. And I'm checking her sclera, that it's nice and white and not yellow and signs of jaundice. I will pull down and check her conjunctiva, and that it's pink and moist and no signs of abnormalities. I'd also be taking a look at her cornea and lens for opacities, and I would need to do that with my ophthalmic scope, and I would put my light on, and you always set your diopter at 0, and I'm going to be checking that the irises are clearly marked and defined. I'm also going to be checking that the pupils are equal and reactive and round to light, and is that reaction brisk or sluggish? And on you today, Pat, it's a nice brisk reaction. I would be doing the right hand always an inspection, and the with the right eye, and the left hand with the left eye. And on this right eye today, I'm going to be shining the light first for direct and response, and her pupil constricts, and I'll be shining the light a second time, and that is the left eye constricts, and that is consensual, I'm sorry, in the pupils, and that is constricting and reacting directly with the first shine, and second one is consensual in the other eye. I would also do that on both sides. I would come over and do the accommodation test by holding my finger at about 10 centimeters and ask her to look at my finger, and then I would ask her to look away at the wall. behind me, and then look back at my finger. And as she's looking at my finger, I will see the constriction with the near vision and the dilatation with looking at something further away. With convergence, I'm going to hold my finger in front of the patient, and I'm going to move in slowly and watch the conjugate and the focus of the eyes normal for the patient to be able to focus until I come into about 5 to 8 centimeters, follow my finger in, and she's able to do that in the front of her nose. I'm going about 5 to 8 centimeters. The other visual test that I'm going to do is your extraocular movement, and we'll do that by going with the letter H. And I'd ask you to follow my finger as I go in a pattern of the letter H, and so I'm going to go down and come back up and go across the middle. I'll go up and down, back up and over, and your extraocular movement is working just fine today. We do that by testing that visual field. The other test that we can do with visual fields test is the fishbowl around the patient, where I'm going to just imagine a fishbowl around the patient, and I'm going to reach behind her. And Pat, if you could please put your fingers up when you see my fingers come into view. And so I'm going to come back here, and I'm going to wiggle for her peripheral vision and that perimetry vision test as I'm coming around and seeing if those come into your view. I want to be sure that you got those. And that could be important for glaucoma or any blind spots. It could be optic nerve, brain, or retina abnormalities, and we would have further testing. Next, I'm going to move right on to the visual acuity test, and that is a Snellen's eye chart. I would ask the patient if she wears glasses. I would have her do it with the glasses on and without them on, and she could put them on, and then we would stand at 20 feet, and we would read the last line on the chart. If she could read line 8, that would be 20/20 vision, and go from there. I would encourage and challenge the patient to read a more difficult line. If she gets more than 2 words wrong, then she has not passed that line. What this test means in the Snellen chart at 20/20 means you have the same vision as what other people can see at 20 feet. And if you had 20/15 vision, you would actually have improved vision than the general population, that you can see at 15 feet what they can see at 20 feet. If you had 20/30 vision, that would be indicative of worse vision. It would mean that you are struggling to see things with greater distance, and the rest of the population can see what you can see at 20 feet at 30 feet. And so I thank you for that. And I'd also have at Pat's age and anybody over 40 or 45, I would have them read this chart at their arm's length, again, with your glasses on. FM. Which line are you reading? You missed that line. You only missed one. So that actually would be a pass for 20/20. And then the line above? CFDHJ. And that is 20/25 vision. But she only missed one in the line on 20/20 as well for your near vision. Does work with the glasses on. And you probably would struggle more with that being nearsighted. Okay, we are going to continue right along here, and we're going to get ready for our ophthalmic exam. And going to get my otoscope ready, set at 0. I would darken the room and have the patient look off in the distance and switch the ophthalmic scope light on my lens disc. And I would hold the ophthalmic scope in my right hand while I'm examining this patient's right eye, and I would hold it in my left hand for the left eye. I stand directly in front of the patient, about 15 inches away, and I start at an angle of about 15 degrees, and I remove my glasses, her glasses off, and I would shine the beam of light onto her eye, and I would put my hand on her forehead, and I would come in, and I'm checking her vessels and following these vessels that are not enlarged today to her optic disc, which is looking orange in color, and no enlargement, no signs of retinopathy, which could be indicative of hypertension if those vessels were large, or it could be a sign of diabetes. We're also checking in the ophthalmic exam for any AV nicking I didn't see, the optic disc to be yellow, and sharp margins, and I would come around on this side. And I'm coming in on an angle. I'm trying not to miss the camera here so you can see me, but I would do the left eye without my glasses on with my left hand, and I would have my right hand on her forehead, and I would come in. I have the red iris following that in, the red light, red shine, and that brings me to the vessels, which then gets me to the optic disc. I see no cotton wool patches, which those could be a sign of floaters. Um, I would also, while I was checking her cornea and iris earlier, I would be looking for opacities and looking for the crescentic shadow, and that could be indicative of floaters. Well, we have now finished the ophthalmic exam. We will move on to the hearing portion of our test, and we're going to first begin with the whisper test. And I would cover one of the patient's ears, and I would be behind her just a couple of feet and whisper baseball, and then I would cover the other ear and be behind her a couple of feet and apple and whisper words, and she was able to hear those. I'm then going to be checking for the patient's conduction, and that is done with the Weber and Rhine test and a 512 HTZ fork that I want to be sure to hold from the bottom so that I don't affect the test results. I'm going to instruct the patient that she's not going to, and so that I'm not talking during the exam, which I've done before, and I'm going to be letting you know that I'm going to place this on the middle of your head, and when you don't hear the noise anymore, let me know. I don't hear it anymore. Thank you. And the second portion of this test is the Rhine test, and that is to evaluate hearing and loss. And if you hear more in one ear, that could be lateralization. And we also we want to be able to hear the ear conduction longer than the bone. And so I'm going to hit this again and put it on your mastoid, and then I'm going to put it in front of the ear. Let me know when you stop hearing it. Stop. Stop. Perfect. She was able to hear the ear longer than the bone, making for a normal finding in that test of conduction of hearing. I then am going to prepare to go on to the otoscopic exam. And so I'm going to get my light off and zip this piece off and put on my otoscope. And I'm going to be making sure that I keep my finger on her cheek to prevent the ear canal damage with any movement. I want to be having safety at all times. I'm going to be holding this like a pencil, and so I can use this pinky to hold the device correctly as I go into the canal. I'm going on an adult. I'm going to be holding her ear with pulling it forward, the auricle. I'm going to go right in, and I'm checking. I don't see minimal cecum. There's no signs of redness or erythema, and the tympanic membrane is intact, no redness, no perforation, and the cone of light is there to the malleus. I'm also going to inspect while I'm here her ear, and there's no signs of abnormalities or lesions. I'm also going to check behind for any tenderness behind her ear that could come from oxygen tubing is a common place that people might get some skin breakdown. I'm going to come around to the other side. I'll come around from the back. And again, we are checking for the color of the tympanic membrane, its position, that there's no signs of perforation or infection. And I would go with my left hand now and click my light on. And I would hold the auricle up and out on an adult. I would be sure that my finger is resting there. Whoops. And in we go. And this is No signs of perforation. Your tympanic membrane is intact. It's pink and gray in color. No redness was noted in the canal or discharge. And minimal sebum in both ears. And the cone of light was present in the malleus handle. We're now going to prepare for the nasal inspection, and we'll always start off with just visually inspecting. Her septum is intact. There's no signs of any past trauma or damage to the outside of her nose or any deformities. I would get my otoscope again, and I'm going to be looking in her nasal cavities, and I'm going to be checking for the turbinates, and they're intact. I should be able to see the inferior and the middle turbinate. The superior turbinate's not able to be visualized. I am going to be seeing with my scope if there's any damage to the skin, any mucosal abnormalities, and I'll be checking for her septum. I'll be looking for polyps, a deviation, or perforation. I would hold my fan back. And I did not see any polyps, any signs of epistaxis, and her mucosa was pink and moist, and no discharge noted. We're going to get ready to go on to the oral pharynx, and we're looking for the rise and fall of the uvula. I'm looking first at the inspection of the lips. They're moist, they're supple, they're not dry, there's no cracks. I would have you open your mouth and stick your tongue out, and I would look at the uvula's rise and fall, the soft palate's rise and fall. I'm not palpating that, but I'm watching it. I see that your tonsils are not enlarged. I would take a tissue and move her tongue from side to side. If you would just move your tongue, I could see that her teeth are fine, her gums are not inflamed. I would want to check the floor of her mouth for any abnormalities, as that can quite often be. There's some veins there, nothing abnormal, no signs of sores or lesions that could be the beginnings of cancer in the oral pharynx. We would be sure to test the gag reflex, and that is present by tapping the back of her mouth to be sure that she gags. We won't do that to you today, Pat. We're next going to move right on to the lymph nodes. We're going to be feeling the pre-auricular and the post-auricular. I'm doing that with the 2 finger pads. I'm feeling the occipital lymph nodes, the tonsillar, the submandibular, and then as we get towards the chin, just below it, the submental lymph nodes, all soft, pea-sized, and palpable with the tips of my fingers. I would also be feeling for the anterior, more towards me, the forward part of the neck, and the posterior towards the back of her neck lymph nodes. And I would be feeling for the suprapubic lymph nodes, and those are on top of the clavicle, on the top. And all those are there today. Some I was unable to palpate, and that's quite all right, because you might not be able to palpate them unless there was some sign of infection. We're going to be moving on to your thyroid and neck exam, and your neck looks fine today, Pat. Will you give me a swallow? And that swallow looks intact. I'm looking for her cricoid cartilage, and everything looks nice and symmetrical. No signs of a goiter or lumps or protrusions, and we shouldn't be able to visibly see the thyroid. When we're going to do the palpation of the thyroid exam, we come around from behind, and I'm placing fingers of both my hands with my index fingers just below that cricoid cartilage. And I'm going to ask the patient to swallow again. And I'm going to be feeling for the isthmus rising and under my finger pads. And you're not always able to palpate. I'm not sure. I felt a little bit there, but didn't feel bad. I'm going to displace the trachea to the right, and I'm going to palpate laterally for the lobe of the thyroid, which is there, and I'm going to do it on the same on the left. I would note the size, shape, and consistency, and identify any nodules or tenderness. If enlarged, I would listen over the lateral lobes to detect a bruit. Pat, I believe that we have completed your examination today, and you are a healthy woman.